Hello and welcome you all to this class on physiology of. I have no disclosures and no conflict of interest. So why physiology? Why do we need to understand physiology? Because unless we understand the physiology, what's going on in the patient and how this ECMO and the patient interacts, we will not be able to properly manage a patient on ECMO. This is my favorite slide. What's the goal of ECMO? It's always to maintain adequate tissue perfusion with oxygenated blood. Delivery of oxygen to the tissues. This equation we have been studied in the first year of our MBBS. The oxygen delivered to the tissues depends on the cardiac output multiplied by the oxygen content of blood. And what factors do the oxygen content of blood depend? Depends on the hemoglobin multiplied by the hemoglobin saturation plus the dissolved oxygen, which is only 0.003 into PaO2. So even if your PaO2 is high, the dissolved fraction of oxygen is only very minuscule compared to the total oxygen content of blood. So if we take a hypothetical case of a normal human being with a cardiac index of around 3 liters per minute per meter square, the blood which is passing through the lungs and entering the left side of the heart is usually 100% saturated. So the oxygen content, if we take the hemoglobin at around 15, comes to around 20 ml per deciliter. So the net delivery of oxygen, the net oxygen content in this oxygenated blood is approximately 20 into 3 liter per minute square, that is 600 ml per minute per meter square. Whereas our tissues need only around 120 ml per meter square. So this amount of oxygen is extracted in the tissues, and the rest of the blood comes back to the venous system, where the content of oxygen in the venous blood is approximately 15 to 16 ml per deciliter, and it is around 70 to 80% saturated. So we see that the delivery is around 5 times that of the requirement. But we also see that the venous blood contains a lot of oxygen in it too. Unlike carbon dioxide, which is easily soluble in the plasma, oxygen needs hemoglobin to care for its transport. And when we come to the oxyhemoglobin dissociation curve, it can be drawn depending on the hemoglobin level. So as the if the hemoglobin is high, suppose it is 15, the oxygen content is in the arterial blood is approximately 20 and the venous blood is approximately 16. Though the venous blood is saturated only 70 to 75%. When the hemoglobin goes down, the arterial oxygen content goes down further to around 15 and the venous oxygen content is approximately 10. And when the hemoglobin is further down to 7.5, the arterial oxygen content is only approximately 10, and the venous oxygen content is approximately 7 or 8. So what we see that even the blood which is deoxygenated, if it is having a high hemoglobin content, its oxygen content is higher than the blood, which is saturated with oxygen, but the hemoglobin content is low. So we need hemoglobin for transport of oxygen. The usual delivery is more than that of our requirement, oxygen delivery. And this excess oxygen delivery takes care that if there is increased requirement in the tissues, then our oxygen requirement in tissues is met. But if somehow our delivery to the tissues is not adequate, so the delivery is not 5 times more than that of our requirement, still, once the delivery to our requirement ratio comes down to approximately 3, it's still the physiology is maintained. But once the delivery comes down to less than twice that of our requirement in the tissues, then the tissue oxygenation is hampered as anaerobic metabolism starts to take place. So our delivery of oxygen to the tissues is quite in excess, and it takes care that if there is any requirement of higher requirement of oxygen in the blood, then there can be increased extraction of oxygen from this delivered oxygen, and the venous saturation will gradually come down. So, if you have a lower venous saturation in the blood, that will predict that either there is an increased requirement, there has been increased extraction, or there is delivery to the tissues is less than that of the optimum. Coming to the ECMO circuit, the main two components are the oxygenator and the pump. The oxygenator consists of hollow fiber membranes with gas which is passing through the hollow fibers, and blood is outside and it comes in contact with the hollow fiber membranes. The gaseous exchange takes place by the help of diffusion. The flow of blood is perpendicular to the flow of gases, so that is proper mixing and more gaseous exchange takes place. In the normal physiology, the single file of RBCs pass through the pulmonary capillaries, alveolar capillaries, and where we have the difference between the gas in the alveoli and the RBCs, the distance is only between that is the alveolar epithelium and the capillary endothelium and a little bit of interstitial tissues, so that it's a very thin gap between the gas phase and the liquid phase. And the blood that is coming out from the capillaries is 100% saturated with a PO2 of around 100, PCO2 around 40. We try to replicate the same thing in the ECMO membrane. But there is a significant difference too, because the ECMO membrane is thicker than that of the capillary endothelium and the alveolar epithelium. Being thicker, it hampers with a little bit of diffusion. The diffusion across the membrane in the ECMO circuit takes place according to the concentration gradient. Remember that it was only a single file of RBCs which were coming in contact with the alveoli in the alveolar capillaries. But here we have a layer of quite a few layers of RBCs. So the layer of RBC which is closest to the membrane, that becomes fully saturated very quickly. But the layers of RBCs which are away from the membrane, there the oxygen diffusion takes place more slowly. So what we try is that the layer of RBCs which are contacting the membrane is not constant. So more and more RBCs come in contact with the membrane, for which we do not try a linear flow within the membrane. We want more and more RBCs to come in contact with the membranes. The carbon dioxide removal is also concentration dependent, but since carbon dioxide is more easily diffusible, then that's why it can be easily washed off. And you can see that the concentration gradient between the oxygen is, if we are giving 100% oxygen, then the early part of the polymembranes will be having a concentration gradient between 760 to 40 of within the blood. Whereas for the concentration gradient for the carbon dioxide will be 45 or 46 in the blood to 0 in the gas phase. On what are the factors does the oxygen, how much oxygen we are delivering through this ECMO machine or membrane depend? First and foremost, the pump flow. So if you have a higher pump flow, more blood will flow through the ECMO circuit, more oxygen you can deliver through this ECMO machine. Second is the fraction of delivered oxygen to this membrane. That is a FiO2 of the sweet gas. So if the FiO2 is low, the concentration gradient is less. So we try to keep it 100% usually in the beginning, and only during weaning in veno-venous ECMO that we come down on the FiO2 percentage. Third, we have all seen that the hemoglobin is a major factor in transport of oxygen. So higher is the hemoglobin, more we can add oxygen to the blood. Fifth is the venous oxygen saturation or content. So if the venous oxygen saturation or content is too low, so even if we add a little bit of oxygen to it, its saturation does not significantly go up. And finally, the membrane surface area. Compare the membrane surface area with the ECMO and to the alveolar surface area. Net alveolar surface area is approximately 150 meters square. That is almost the size of a football field, whereas the membrane surface area is around 1.8 to 2.4 meters square. So we have to do the function of the lung through a very small surface area. The carbon dioxide removal depends on only the sweet gas flow. So if you have a sweet gas flow higher, it will wash off the carbon dioxide faster. It's almost equivalent to your minute ventilation in the ventilator. So if you have a higher PCO2, what we do is we go up on the minute ventilation. Likewise, in ECMO, if the patient has a higher CO2, we want to wash off CO2 more, we go up on the sweep gas flow. And the delivery of oxygen to the tissues depends on the net oxygen content in the blood. And the net oxygen content in the blood will depend on how much oxygen we are adding through the ECMO, as well as what is the native oxygen, the oxygen oxygenation power of the lungs. And also, there is some amount of mixing that will come in the later slides. So, the net oxygen content will always be dependent on these two factors. So these two places, the ECMO membrane and the alveolar membrane, there the oxygenation is taking place. Usually the lungs, when it is not functioning properly, ECMO provides a major oxygen to the blood. Coming to the mixing effect. So, if I give you an example, if the patient has a cardiac output of around 7 liters and the ECMO, venovenous ECMO flow of around 4 liters, if we think that the venous return, only 4 liters of blood will come in the ECMO circuit, and these 4 liters will go back to the right side of the heart fully saturated. But it is mixing with the venous return, which is not passed through the ECMO membrane. So that is 7 minus 4, the 3 liters of venous return will be coming to the right atrium, which is not passing to the ECMO. And it is mixing with 4 liters of ECMO flow, that is 4 liters of oxygenated blood mixes with the 3 liters of deoxygenated blood. And this mixing takes place in the right side of the heart, and we have a net oxygen content whose oxygen saturation will not be 100%. So this blood will pass again through the lungs, where a little bit of oxygenation may be taking place or may not be taking place, and that is passing through to the left side of the heart and to the tissues. Suppose now if the patient has fever or a sepsis develops and the cardiac output goes up to 10 liters. Venous return has gone up to 10 liters. But if you have not gone up on your ECMO flow, then only 4 liters of blood is getting oxygenated, whereas the venous return is 10 liters. So 10 minus 4, 6 liters of deoxygenated blood is mixing with 4 liters of oxygenated blood. So the net oxygen content goes down, and hence the saturation goes down further. That is why in venovenous ECMO, we target at least 60% of the cardiac output should be passing through the ECMO. And we have to go up on our ECMO flows when the patient's cardiac output is higher. The CO2 exchange, it is a direct function of the sweep gas, as we have told earlier, and it is CO2 washout or the CO2 decarboxylation through this ECMO machine is a much more efficient function than the oxygenation function through ECMO. So in an ECMO machine, you have a flow meter, that the total flow of gas that is passed given into the ECMO membrane, and the blender, which will determine how much is the oxygen content, that's a FiO2 in this sweep gas. So our net sweep gas flow, that controls the CO2, whereas this blender, that will control the oxygen control, oxygenation part of the blood. Always remember, venovenous ECMO is a series circulation. Why we are saying series? Because the venous return which is coming, a part of it going through the ECMO circuit, but it is again coming to the right side of the heart. So the blood, whole of blood is coming to the right side and then to the lungs and to the left heart and then goes to the systemic circulation. So it's a series, part of blood in ECMO and the rest to the right heart. And ECMO blood is also coming to the right heart and then to the systemic circulation. Whereas the VA ECMO is a parallel circulation. Why we are saying a parallel circulation? Because A part of the blood which is going to the ECMO circuit does not come again to the left side of the heart, but it goes directly to the arterial system. So the arterial system is getting blood both from the heart through the nadicular cardiopulmonary system as well as through the ECMO circuit. So it's a parallel circulation. Now coming to the two or three peculiar things that occur in veno-venous and veno-arterial. So in veno-venous, what we are doing is we are taking blood from the right side, passing it through the oxygenator and again giving to the right heart. And if the cannula are close together, a part of the blood, which is oxygenated blood returning from the return cannula, is sucked in through the venous drainage cannula. So that causes a recirculation. So oxygenated blood is again coming to the ECMO circuit. It reduces the efficiency of the system. You are still having a 4 liters of ECMO flow with it getting adequately oxygenated blood. This oxygenated blood is again passing through the venous drainage cannula. So the net oxygen delivery to the tissues is hampered. So to prevent recirculation, we keep the cannulas tips far away. Coming to the veno-arterial system, in veno-arterial, what we are doing is that we're taking out blood from the right side of the heart and giving it to the arterial system to maintain the tissue perfusion. But giving back blood to the arterial system increases the afterload. So we have one side, a failing heart, and since the tissue oxygenation is not adequate, we are giving blood back to the arterial system. So the afterload increases. The failing heart is beating against a higher afterload. What happens is that the LV dilates. So LV distension occurs. So there is inefficient blood pumping through the further pumping through the LV is hampered. And this is the reason ECMO, VA ECMO, favors tissue oxygenation, but it does not favor the heart. It is not friendly to the heart. So in VA ECMO, there is a blood pump, and though the preload comes down because we are taking out blood from the right side, we are increasing the afterload of the left side of the heart. So always remember that the patient may land up in LV distension after you have put the patient on ECMO. So if this is the X-ray at the time of putting the patient on ECMO, if after 6 hours you have froth in the tube and your lung X-ray is showing increase in pulmonary edema, just think that the patient is having an LV dysfunction, further increase in having an LV distension. So this is a common thing that we have to take in mind. And because the LV is pumping against a higher afterload, the pulse pressure further goes down because of less efficient contractility. The pulse pressure can go down, and you have to always try to get some amount of pulsatility during the veno-arterial ECMO so that you have adequate emptying of the LV. Coming to the pump segment. The pump in our modern ECMO machines is a centrifugal pump. There is an inlet, there is an outlet, and in between there is a veins that is almost like a fan's blade. And because of the rotation of these fans blade, you will generate a force, this centrifugal force, to push the blood through the circuit. Since it's a centrifugal pump, the flow in the centrifugal pump, we all know, is dependent on the preload. That's a venous content. If the preload goes down, the flow comes down. And if the afterload is high, the flow goes down. So we target lower afterload with medications, with other mechanisms, and we try to have adequate preloading in these patients. And the flow through the circuit is inversely proportional to the radiation, inversely proportional to the resistance in the circuit. And on what factor does the resistance depends? The higher the length of the circuit, the larger is the resistance. And resistance is inversely proportional to the fourth power of the radius. So the flow will be proportional to the fourth power of radius. If the radius of these ECMO cannulas, that the diameter of the ECMO cannulas and the circuit goes down, then the flow is significantly hampered. So in pediatric population, we have the flows going down further because the radius of these ECMO cannulas and the circuit is lower. And always remember that we are pulling from the venous system. So the drainage is by a negative pressure and pushing is by the positive system. So the return is by the positive force. And because of the negative pressure generation, there is a chance that the venous walls can collapse on the cannulae. So that is why we try to keep the negative pressure minimum. Since we are draining blood from the IVCs and the cannula to the IVC passes from the femoral veins, the venous drainage is cannula are usually longer. And we try to keep the largest size venous drainage cannula so that the resistance is least. Whereas, since you're giving back blood in a positive pressure, our return cannulas, which we are placing either in the jugular vein or in the arterial system through the femoral artery, it can be a smaller length as well as a smaller diameter. And we try to keep the tubing of the circuit as minimum, as smaller as possible to decrease the resistance as well as to decrease the hemodilution when we are going on. Finally, what happens to the inflammatory system in the body? Because extracorporeal life support or ECMO, it facilitates further protective lung ventilation as well as we are able to give lung rest and myocardium can be given more rest with the tissue perfusion increase. The SIRS action activity, there's an inflammation in the lungs and that because of the tissue hypoxia that goes down. But remember, this circuit is a non-endothelial surface. So when blood comes in contact with the non-endothelial surface, there is activation of complements, activation of the coagulation factors, the platelets are getting activated, leukocytes are activated, and there all those increase the inflammatory systems. So there is a balance between the inflammation and the decreased inflammation. So this balance has to be maintained. Coming finally to the causes of low oxygen saturation of ECMO. So if you know the physiology of ECMO, you can deduce if the patient is having a low oxygen saturation in spite of you putting the patient on ECMO for the lungs. What can be the causes of low oxygen saturation of the patient? I'll not enumerate them, but I'll ask you to write down what may be the causes of low oxygen saturation on veno-venous ECMO. put them now in the chat box, and let's see how many points you can get. Thank you. And these are the take-home messages. Always remember that the gaseous exchange is dependent on the concentration gradient, and the oxygen delivery is dependent on the ECMO blood flow and the hemoglobin. CO2 washout is dependent on the sweep gas. This ECMO pump is a centrifugal pump. It is dependent on the preload and afterload. The flow in the pump is dependent on preload and afterload. VV ECMO, there can be an recirculation. VA ECMO, there can be LV distension. So there is a very good article by Robert Bartlett. You can note this down and go back, see this article. It's very useful article. It's freely available, and you will get an understanding of the gaseous exchange in these ECMO membranes very easily, very lucidly written article. Thank you all.